As you can see from the slides, as Deborah said, the evidence is absolutely overwhelming, and I thought I'd just simply overwhelm you with it. And there are many, many more. I had to actually take some off the slides so it wasn't so confronting. But you can see there is an enormous range of studies and methodologies outlining these issues. So research into this area has grown exponentially over the past 20 years. This has been further supported by the research in neuroscience, which confirmed what many already knew and which has also contributed to new understandings and insights. Despite the research and improvements in understandings of the impact of trauma on mental health generally, there continues to be difficulty for many mental health services to listen to and respond to consumers disclosing current and historical abuse, and to take account of these issues in treatment responses. And I think that is such a critical issue. People end up medicated and in treatment modalities that will not help them recover from their histories of abuse. I began this presentation talking about belief and the central role it can play in responding to victims of violence. It remains a consistent finding that not being believed is the uppermost fear of most survivors of interpersonal violence and abuse. Studies from services for sexual assault, domestic violence and child abuse note that fear of disbelief is pervasive and heightened when clients interface with government systems, including health systems. How mental health responds to that fear is critical in establishing services and environments capable of hearing and asking about violence. In the report, They Never Asked Me Anything About That, which was by Leslie Lang in 2010, women who had experienced domestic violence and then came into contact with the mental health system had this to say. They mentioned to me the strategies of getting rid of the idea of killing myself, so addressing mental health. They haven't mentioned to me how to help myself as a victim of domestic violence. I have to apologise for some of the comments. I'm hoping it's not offensive to people in the room, but it's important to see how powerful women feel about this. Psychiatry hasn't come that far since performing lobotomies. One psychiatrist, I didn't know whether I drank because I was depressed, or I was depressed because I drank, and I tried to tell them that the old man was bloody punching me over and being cruel to the kids, and I was too scared to escape, and they didn't want to know. So those professionals that I went to, they are psychiatrists, for Christ's sakes. They're psychologists, they're therapists. Why did it take my son? Why did it take the cops? And why did it take me coming to this centre after I had lived it? If I had gone to the first couple of therapists and if they'd picked it, well, that would have been like 10 or 11 years ago. I would have been out of there instead of being with him. It would have been 10 years with him, not 20 years. Now, the frustration of this last comment highlights the dilemma for clients when trauma is either not believed, is discounted, or is minimised. It risks leaving consumers exposed to ongoing violence and abuse, as well as escalating serious mental health symptoms such as suicidality, depression and psychosis. And for some, it means prolonged and ineffective treatment in the system, sometimes over many, many years. And certainly when I was starting this work, I was working with people that had been in the system 20 and 30 years. And with good intervention over, I might add, quite a long period of time, they were able to move out of that system. And I think the shift is good for workers as well as for clients. There is so much more reward for the work that you do when you begin to take on some of these issues. Further and importantly, we know that most children who have experienced abuse, particularly those that have experienced child sexual assault, will carry the secret of the abuse into adulthood. Studies examining disclosure consistently find that less than 25% of children disclose after sexual assault. Most will not disclose until they are adults, if at all. We also know that the longer the abuse continues, the longer the secret is kept, the greater the severity of the symptoms. This is ECAV's little poster presentation. It's a very hopeful poster presentation, and we have that outside. And it looks at the fact that Carly has a history of abuse. You can also see that she's got some good life events and there's levels of resiliency, but inevitably, in this instance, she enters the mental health system. Now, the capacity of that system to identify and respond to Carly's trauma history provides an opportunity for her to take a different pathway, one that recognises her abuse and therefore is more able to meet the treatment needs of this young woman and to help her move towards recovery. One could argue that the risk of not believing poses a greater threat to consumer wellbeing and recovery than the risk of workers providing a believing, compassionate and respectful response. In the book Addressing Violence, Abuse and Oppression by Fawcett in 2008, women who had experienced domestic violence and who then became involved with mental health services found themselves subject to three main types of responses. The first was silencing. The second was not inquiring about or wanting to know about domestic violence. And the third was about a mental health diagnosis being used to discredit the woman's claim of domestic violence. Now, these three responses clearly encapsulate the difficulties facing consumers who are trapped within what amounts to a catch-22. That is, that being exposed to violence and abuse will commonly result in mental health or disorder, but the mental health or disorder then being used by health professionals to discount the violence and abuse. And there is the nub of our problem. Mental health workers need to be aware that they too are operating within a culture that has particular ideas and beliefs. Some of these are not based on the evidence and may be contrary to the best interests of this client group. Indeed, the practices may be counterproductive to effective mental health treatment. The evidence is clear that the legacies of interpersonal violence and abuse is the day-to-day reality for many consumers. And this is a fact. Just as Deborah said, it's an absolute fact. If disbelief is the greatest fear of many victims, then belief by professionals can become a powerful tool in developing safe, trusted and supportive relationships. With effort and commitment to policy development and training, this will promote trauma-informed environments. Like all political movements, changing entire systems requires a groundswell of like-minded people. The women from the report They Never Asked Me Anything About It made recommendations to service providers. I've put some of those together. It talks about believe us and trust us and treat us with respect. Respect our own understandings. Don't blame us for our situation. Be aware of the mental health implications. And be aware of the abuser's tactics. So I suppose my question to the audience today is, how do we implement these recommendations into an already congested system, and how do we introduce these ideas into our work practice? To date, there has been a struggle for many within the system to locate the high mental health, the high levels of mental illness and disorder as acts of humans. There has been more of a desire to locate it in or pathologise the consumer or see it as a biological model solely. So if we are to support clients and consumers on their journeys of healing and recovery, then I argue that trauma-informed care requires us to have a politics of belief. Thank you.